going to be talking about discharge planning. A team of healthcare providers join forces to reach the goals for the patients. This team includes physicians, RNs, social service, insurance providers, case managers, home care nursing agencies, respiratory therapy, HMEs, pharmacists, OT, and PT. Orders from the physician need to be formed before discharge. These orders include equipment settings, weaning orders, and patient assessment criteria. The patient and family's participation is key. Patient and family's needs and wants must be met before discharge. The family needs to understand that this is a huge responsibility. All medications must be obtained before discharge and all questions must be answered. Pre-discharge criteria include the patient has to be medically stable, they have to have a secure artificial airway, they have to be adequately oxygenated at FiO2 of 40%, they have to maintain adequate ventilation on standard ventilator settings, the location of the home has to be safe and must be assessed before a vent can be put in. It also has to be fundable to the family and the patient. More than one caregiver has to be available in case of an emergency, and adequate circuits to hold a vent has to be in place. The caregiver must understand that inadequate care of the ventilators could put the patient's life in risk. An example is infection control. Appropriate hand hygiene and barriers should be used. The caregiver must also understand the ventilator's operation settings, troubleshooting, and ventilator circuit changes. Ventilator alarms. This includes high pressure limit, and this is due to secretions in ETT, airway condensation in the tubing, a kink in the vent tubing, the patient biting on the ETT, the patient coughing, gagging, or trying to talk, increased airway pressure from bronchospasm or pneumothorax. The low pressure limit includes vent tubing not connected, displaced ETT. High respiratory rates include patient anxiety or pain, secretions in the ETT or airway, hypoxia or hypercapnia. Low exhaled volume is due to vent tubing not connected, a leak in the cuff or inadequate cuff seal, and occurrence of another alarm preventing full delivery of the breath. Home care. Ventilators must have a scheduled maintenance every 6 to 12 months. Vent patients meet with PT and OT to maintain range of motion and ADLs. Respiratory therapists set up the ventilators and perform general maintenance. The respiratory therapists are responsible for adjusting the settings on the vent according to the physician's orders. Nurses are in charge of assessment, patient safety, medication administration, suctioning, making sure the vents are working, and if there are any new physician orders, to notify the respiratory therapist, and documentation. Pediatric home ventilation is similar to adult care. They have the same team of professionals with pediatric care. The patients and kids must understand the process of home ventilation. Counseling of families' strengths and weaknesses and resources should be done for a good transition from the hospital to the home. Involve the child in their own care.